I'd like to present one of our cases of a 59-year-old woman with a 7-month history of left flank burning who had a CT scan demonstrating this lesion, which amongst other things was invading into the psoas muscle, and amazingly she did not have any sites of dissemination. We treated her with Sunitinib therapy, and within a few weeks actually of receiving Sunitinib therapy, the mass decreased in size and her pain actually disappeared. Unfortunately, it was still radiographically invading into the psoas muscle. And now, a year later, with further therapy, we have made this thing smaller and volumetrically quite so, but it's still pasted onto the psoas. Serenity has now decided, enough is enough. We're going to take her to the OR, and we'll find out how easily this comes out. The challenge for this patient is that we need therapy that can effectively downsize her disease, downstage her disease, and prevent formation of metastases. Because bear in mind, even if you get the primary tumor out in these complicated cases, distant dissemination is the cause of death in the majority of patients. We fortunately now in 2009 have a number of studies that have asked the question of whether with targeted therapies we can downsize or downstage primary renal cell carcinomas, both in the metastatic and non-metastatic setting. And I'm going to talk about the 3 prospective trials where we have some preliminary or mature data. First is Kimran Rathmel's study, where she took 30 individuals who had somewhere between stage 1 and stage 4 disease. 50% of these were with stage 4 disease, and treated them for, on average, about 1 month of sorafenib therapy, and then within 3 days of the last dose, took them to surgery. And what was seen there was that clearly there was a decrease in the size of the primary tumor from 8.7 centimeters to 7.9 centimeters, and that enhancement also decreased. Here are examples of tumors that changed, one that developed a lot of necrosis on the top, and the second that clearly decreased in size. The surgical outcomes with this in this study and most of the other studies that I'm going to talk about really were pretty decent, and there weren't any major morbidities attributable to prior systemic therapy. Brian Rini presented a phase 2 study of Sunitinib patients with renal cell carcinoma and unresectable primary tumors. Now, very important to look at the box on the left and look at how this was defined. Unresectable is defined as bigger than 15 centimeters, bulky lymphadenopathy, venous thrombosis, or proximity to vital structures. And I'm sure there are some surgeons in the room who would say, well, that's not unresectable. But I think if we think about the community standard and making a surgery that may be very complex in the community, somewhat less complex, these are very valuable criteria. And these individuals received 50 milligrams continuous dosing of Sunitinib. These were the reasons. The red arrow, 32% had bulky lymphadenopathy, 32% had proximity to vital structures, 21% had venous thrombosis. 37% of these patients by these criteria were converted to resectable. There was 72% rate of shrinkage of any amount, and the median shrinkage was 19%. Here's an example of an individual who was downsized and also arguably perhaps downstaged, where the tumor became quite a bit smaller and a previously impossible partial nephrectomy was performed. We just recently published our presurgical Bevacizumab experience with 50 individuals who received 4 cycles of presurgical Bevacizumab. All of these patients were previously untreated and had metastatic disease. This is very small, but the bottom line is that this was a poor, intermediate to poor prognosis group of patients, had multiple sites of metastatic disease elsewhere. And the primary tumor shrinkage occurred in about 50% of patients with 4 cycles of Bevacizumab. None of these people reached RECIST criteria, and I'd have to say that none of these people were downstaged, but those individuals who got in the study were not actually selected for unresectability of their primary tumor. They were basically selected for actually ability to perform the procedure ahead of time. In terms of toxicities with Bevacizumab, At 4 weeks postoperatively, 9 patients had not completely closed their wound. 5 of them could proceed just as scheduled. 2 had to wait a few additional weeks. And 2 patients did actually have to come off study because they just weren't healing, and they restarted about 4 months later. And then 1 patient 3 months later did actually have a fascial dehiscence. Our retrospective review of all comers with Bevacizumab and other TKIs compared this to patients who had undergone immediate cytoreductive nephrectomy. And the bottom line here again was that superficial wound healing was the one thing that came out in a multivariable analysis, but clinical outcomes and surgical outcomes really were not substantially different in either group. So in summary, what we can say is that is this safe? I would say yes with the data presented. Are we shrinking primary tumors? Yes. How much? Somewhat. Downstaging occurring in some cases. So can we decrease the size of primary masses with the currently available therapies? We sure can. Can we convert patients to partial nephrectomy? In some cases. Are we decreasing invasion into adjacent organs? I would argue that that's probably something that we're not so good at. I know there are some anecdotes of IVC shrinkage with Sunitinib as well, but it's certainly not the rule. And are we changing the biology from invasive to non-invasive? This is certainly unproven. So what are the possible solutions for this dilemma? Maybe more potent anti-angiogenic agents will make a difference. Possibly we actually need to leverage these agents. Anti-angiogenesis may not be sufficient. We may need to have some sort of an anti-primary tumor or anti-tumor cell therapy. So combinations perhaps of chemotherapy plus anti-angiogenic therapy may actually leverage these agents. And the other thing is these properties of invasiveness are clearly a major dilemma. And are there therapies out there that can actually alter these invasive properties? It's not clear, and I think this is where we need to really think about it, and perhaps more sophisticated imaging would be useful. Now, the elephant in the room here is that once we achieve this local control, we're not necessarily achieving systemic control. And the question is, do these systemic therapies, these anti-angiogenic therapies that we're using so much now, are they actually anti-metastatic? What we presented earlier this year in cancer was that in individuals who were treated with anti-angiogenic therapies and had metastases, compared to individuals who were treated with immunotherapies, they had good control of existing sites of disease, but there was a higher percentage of individuals who failed at new organ sites relative to those individuals who are on immunotherapies. And there are these 2 very interesting and controversial papers that have come out in Cancer Cell a few months ago demonstrating that in animal models of anti-angiogenesis therapy that there is an increase in invasiveness, at least in the RIPTAG model, and in the tail vein type of a model treated with anti-angiogenic therapy, you end up having increased rate of metastasis formation. I'm not saying this is happening in humans, but it does make us think about what the mechanism of action of these therapies are and what mechanism of action of therapy is that we need to prevent these individuals from developing metastatic disease. So if we think about this mechanistically, what we need is we need drugs that will essentially prevent survival of circulating metastatic cells, prevent generation of micrometastases. And the biology of that is gradually evolving, but I don't think that it's quite mature yet. Possibly blocking CXCR4, altering extracellular matrix expression, or perhaps even immune modulating cells, agents at this point would be things that we have to think about in addition to things therapies that can locally control. The problem with any treatment like this and in the high risk setting is how do we monitor efficacy? We don't have an assay yet for circulating tumor cells for renal cell carcinoma, and hopefully we'll have one soon. Possibly things like circulating endothelial cells are valid biomarkers, but that's not been validated. And also circulating factors that are associated with metastatic potential could possibly be used. But these are the sorts of tools we have to develop. Amado Zurita, who I think is here today, is working on this, as are others, and I'm hoping that over the next couple of years these tools will become available. So in conclusion, anti-angiogenic therapies are capable of cytoreducing primary tumors. but not consistently. I don't think there's any evidence that these agents are necessarily anti-metastatic. That's